Okay. Smoking. Let's talk about smoking, or maybe not smoking. What medication can you prescribe to your patient that wants to quit smoking? Chantix and Wellbutrin are some that are commonly prescribed and seen in exam. Okay, Chantix and Wellbutrin. But technically, if a patient is on Chantix and Wellbutrin, they can still continue to smoke. I mean, with the Chantix, they might be feeling sick or whatever, but they can. You can also put them on a nicotine patch or tell them to get some nicotine gum. But if you do give them that education, you have to remind them to be careful, because if they're smoking and chewing gum and having a patch on, they can have way too much nicotine, right? Way too much nicotine for those patients. All right, so let me just, what do you see in all these three pictures? What do you see in all these three pictures? What is this called? Well, hopefully you said that these are Koplik spots, and these are seen in rubeola. Okay, so remember the O and the O, or measles, right? And measles, as we know, can be prevented with the MMR vaccine. But these red lesions that are found inside the mouth are usually an early sign of measles. So it can appear a couple of days before the actual measles rash. So just be familiar with Koplik or with rubeola measles. All right. Acne. So my notes are here out of order. There's one or two exam questions will ask you about acne. So let me ask you this. Patient comes in, they have some kind of acne on the face. Which type of acne would you treat with topical treatment like benzoyl or topical antibiotics? Would it be A, cystic acne, or would it be mild acne? Well, hopefully you said mild acne. So if you are given a picture, a patient, I should say, and they have mild acne and it's asking you to treat them with topical things, you're going to choose the mild, okay? Cystic, that's when it's bad, right? That's bad. They need more than just some topical stuff. So first line, we usually use some kind of topical. Then we move to the oral antibiotics like Daxi, right? And then eventually, when it's cystic and it's really bad, we can do Accutane. So Accutane is category X. So obviously that's bad, and a lot of times like the derm will prescribe that because there are rules that go with it because it is such a potent drug. All right. So what do you see in all these pictures that are highly related to HIV infection? Well, if you said that you see Kaposi sarcoma, then you are correct. These lesions on the body, on the face, all over are called Kaposi sarcoma, often related to HIV, okay? And since we're talking about HIV, when do you start treating a patient with meds when their CD4 falls under what number? Well, hopefully you said under 200, right? That's when it's actually considered AIDS. All right, good job, guys. Oh, can you give live vaccine in HIV? No. You cannot. So no MMR, no varicella, no flu mist. They're immunocompromised. We are not going to give them any live vaccines, guys. No, your live vaccines. All right, this dude comes in and they have these dark bluish grayish macular lesions or spots. What are these? Well, hopefully you said Mongolian spots, right? Mongolian spots. And these are usually found over large areas, right? And they're found in dark-skinned people, really no big deal, or people, children, I should say. So this patient comes in, and they're a UPS worker, so they handle a lot of different things. And they tell you that they developed this pustule skin lesion that eventually formed into an ulcer, and it's black, okay? What are you thinking here? Well, I hope you are thinking, and you might not be thinking anything, cutaneous anthrax. This is anthrax, you guys, right? Sometimes this pops up on the adult general exam. And this is really the most common type, the least dangerous. And how do you treat this? Cipro. Okay, Cipro for a long time, like 60 days or so. Okay, so an FQ like Cipro, and Doxy is an alternative. All right, so patient comes in, and you see this, and it's swollen, and it's red, and it's painful, and it's tender. What are you thinking? Well, I hope you are thinking that this is gout, okay? You're thinking gout. So they're having an acute gout attack. And what would you treat them with? Would you prescribe them some NSAIDs or would you give them some Tylenol? What is the first line? Well, I hope you said some NSAIDs, right? Like Indocin. That is the first line. All right, now let's say a patient comes in and they have a documented history of gout. What would you prescribe to prevent gout complications, like joint destruction or deformity and all those other things? What would you prescribe? Would you give them some Tylenol or would you give them some Probensid? You'll give them some Tylenol, right? You would give them, did I just say Tylenol? You would give them some Probensid to prevent. P for P to prevent. And it's a uric acid lowering agent. So sometimes if some patients can't do alpunerol, they can do this. So alpunerol is obviously another one. With alpunerol, you got to check their CBCs, right? It can affect the bone marrow. And everybody always gets confused. Can you give alpunerol in an acute attack? Can you not? So basically, how it's done is they don't start alpunerol in an acute attack, but if they're on it, you can continue it, okay? And if you want to start them on it, you want to wait like 4 to 6 weeks after the attack, okay? Hopefully that makes it clear. And there's other, preventative medications, but just be familiar with the most popular ones, like Probensid and alpunerol. And for acute, you want to think NSAIDs. Actually, I wanted to say something else. What hypertensive medication should you avoid or use in caution with someone with gout? What kind of hypertensive medication should you use in caution? Hopefully you said thiazide diuretics, okay? That class of diuretics can increase uric acid, okay? Also thiazide diuretics increase your glucose, right? So you want to be careful with diabetics. It can lead to hyperglycemia. They can also increase your lipids. So got to be careful with someone who has a hyperlipidemia. And then they also increase the uric acid. So you got to be careful in gout, right? So those are the 3 things that thiazide diuretics can increase. And then pretty much everything else can, lower, everything else that you can think of with thiazide, lower it. And what are some triggers for gout? Thiazide diuretic, some purine-rich foods, right? Some organ meats, sweetbreads, spinach, seafood like sardines and anchovies. Gross. Those both sound terrible. Oatmeal, alcohol like beer, aspirin, and there's a longer list, but these are some main ones. All right, moving on. Okay, so let's talk about this. A young patient comes in to see you, and you're during the yearly exam. And on the physical exam, you see these things in the folds of the body. They're velvety colored skin discolorations, okay? What are you thinking? Are you thinking insulin insufficiency or are you thinking a fungal infection? Well, hopefully you are thinking insulin insufficiency. So you want to work them up. You want to check the sugars, right? check the sugar, whether it's whichever sugar you're going to be able to recognize, A1C or fasting or whatever. Okay. Let's say a patient comes in and they are complaining of frequent infection. What do you want to work them up for? Well, again, I hope you said you want to work them up for diabetes or some kind of insulin insufficiency, right? So again, you want to check sugars on that patient, right? And what are these velvety things called? I can never pronounce acanthosis. Yeah, so I'm just gonna leave it up here. You guys can read. All right, let's do some diabetic stuff. So you're not in shock when this part on the exam comes up. You know what to expect. Let me start with this. When do you start a patient on Lantus, like a long-acting insulin? What should their A1C be at? 9 or 10, right? 9 or 10, 9 or double digits, basically. So 9 or 10, depending on which guideline you're looking at. But for the exam, I would remember 9. And the patient is taking Lantus, and you have to increase the dose because they're not a goal yet. How much and how often do you increase the dose? Yep, you increase the dose 2 to 3 units every 2 to 3 days until a goal, okay? Right, so we usually start our basal insulin at 10 units a day, and then we increase it, or 0.2 I can't talk. 0.2 per kilogram, right? So whether it says, it might say basal, not Lantus necessarily. All right, so let's move on to the next question. And a 59-year-old comes in and they have type 2 diabetes. By the way, the exam is going to be mostly about type 2 diabetes, not type 1. And their A1C is at 8.7. They're on glyphosate 5. They're on metformin 1,000 day. What 2 things would you do? Select 2. Well, I hope you said you would increase the metformin and you would check their urine for microalbumin, right? You always want to max out that metformin first so they can get, 2,000 milligrams per day. And then you want to check the urine, the microalbumin, because that's an early indicator of kidney dysfunction, right? So those are the 2 things you would do. You wouldn't start them on Lantus because they're not at 9 yet, and you wouldn't increase their glyphosate either because you want to max out that metformin first. Okay? One other question. So you are seeing a homeless patient and their A1C is at 11. Holy smokes, right? What do you do for them? Do you give them metformin or do you give them insulin? Hopefully you said metformin, okay? You do not want to give this patient insulin because you do not know when their next meal is coming from, okay? So you're going to treat them with oral stuff, things that have less chances of hypoglycemia, okay? You don't know where the meal is coming from. All right. If patient is stable, they're diabetic and they're stable and their A1C is good, when should they follow up with you? Hopefully it's at 6 months. If they're stable, they can come and see you every 6 months, see how things are going, and you're going to check their A1C, do their labs, check their urine, things like that. What if they're unstable? When would you want them to come back? You want them to come back in 3 months, right? You want to check the A1C and see what it looks like, see if you need to adjust anything. All right, a couple more diabetic questions so you know how to prepare for this exam. All right, so the left side is the A1Cs and the right side is intervention. So expect these type of questions on the exam, okay? Pause me for a second and work these out. What would you do? All right, so I'm gonna tell you what you would do. So with the 4.6, the A1C of 4.6, you would stop the metformin, right? Or whatever PO medication they're on. With the 6.5, you would do nothing. You just leave it. Keep the dose the same, move on with life. And for the 9.9, because it is above 9, you would want to start them on some kind of insulin, right? Make sense? Now you know what to expect. Let's do one more. Sometimes people say they have like 4 or 5 of these type of questions. I had one, I think. So pause me and work this one out. And now that I'm on pause, what would you do? 4.3, you would decrease that Lantus, right? Or maybe you see it, maybe slowly decrease it. 8.2, you would increase their metformin, right? And 6.5, you would keep the same. So it might give you some kind of scenario ahead of time or something, don't worry about it, as long as you can just figure this out. All right, let me ask you, what are some of the goals for our diabetics? What would you want an elderly patient to stay under? With the A1C to be under 8, right? We want that A1C to be under 8. They're older, they usually have comorbidities, so we're not as paranoid about their A1C. But if they're younger and they're healthy, we want to keep that A1C under 7, right? And if they're pregnant or diabetic type 1, we want to keep it under 6. And how do we diagnose diabetes? What do we need to actually make the diagnosis of diabetes? Well, we can do a fasting, right? And it should be over 126 times 2, right? So either 2 different samples or twice in the same sample. We can do a random, and that would be, it should be over 200 with signs and symptoms. We can do a 2-hour plasma, over 200, and we can do a A1C over 6.5 times 2 samples, or it could be the same one, but twice to diagnose diabetes. All right, let's move on from diabetes. So a patient comes in and they have those typical signs and symptoms of strep throat, right? So they have a fever, no cough, that sudden onset of sore throat, swollen lymph nodes, exudates, and their throat looks like that. What would you prescribe them? First lines, guys. Penicillin V. Penicillin V is a good one. Penicillin G, IM, or moxicillin. Okay, penicillin V, and all the other couple ones I said. All right, now a 17-year-old comes in and sees you, and they have a sore throat, but it's been going on for a while, and they're so tired, and they just can't shake this off. And they were negative for strep. What are you thinking? Hopefully you're thinking mono, right? That sounds like mono. Kind of looks like strep too. So you can do a mono spot. They'll test positive for Epstein-Barr virus, and you are just going to treat them by the symptoms, right? Are you going to give them an antibiotic? No, you will not give them an antibiotic, right? You should not be prescribing amoxicillin or anything like that to those patients, because they will come back. 90% of the time, they are going to come back with a rash, okay? So just supportive treatment. And remember that the spleen can be enlarged, right? So no sports for that patient for 4 to 6 weeks after the symptoms resolve. And you could do an ultrasound too to confirm, okay? The last thing we want is that spleen to be bursting on us or on them. All right, so patient comes in and they're complaining about headache and facial pressure and ear pressure, and it's worse when they bend over, and decreased smell, and they're congested, and they're just miserable. And they said they felt better, but then they got worse again, and it's been going on for like 10 days or longer. What are you thinking? Well, I hope you're thinking bacterial sinusitis, right? And what is the first line treatment for bacterial sinusitis? Augmentin, the drug of choice by guidelines, okay? What is a complication of untreated bacterial sinusitis? Well, if you said periorbital or orbital cellulitis, you were correct, guys, okay? This requires urgent evaluation, okay? There's going to be ocular pain, there's going to be eyelid swelling, there's going to be redness. They're not going to be very pretty. So that is a complication. All right. since we're up here, let me ask you this. Patient comes in and they have some pale and boggy mares, and there's a runny nose, and they're just not feeling well here. What are you thinking when you hear those pale and boggy? Well, I hope you are thinking allergic rhinitis, right? And how do we treat allergic rhinitis? Well, first we want to avoid triggers, right? But then also we could do for controller or prevention meds. We can do, the first line is intranasal steroids, right? And if we want to relieve their signs and symptoms, or for those acute symptoms, we can do some antihistamines, okay? So let me ask you this. Choose which med has the least side effects. And we're still on the topic of allergic rhinitis. Which one has the least? Is it A, antihistamine, B, Afrin, C, intranasal steroid, or D, cromolyn? Well, I hope you said cromolyn is the one with the least side effects, okay? That's mast cell stabilizer, okay? Fewest side effects out of those three. Antihistamines, we know they're anticholinergic and they have a lot of side effects. Afrin, you know, it's a topical, decongestant. You could have rebound congestion with that one. Intranasal steroid, yes, it's a preventative, but it's a steroid, so it definitely has more side effects than a mast cell stabilizer. Whew. All right, moving on, my people, moving on. So patient comes in and they're complaining of proximal, whooping, persistent, uncontrollable cough, okay? Almost like a gasping sound. What are you thinking? Well, I hope you're thinking pertussis. Pertussis, right? And that's bacterial. And how are you going to treat them? The drug of choice is a macrolide. The drug of choice is a macrolide. Azithromycin, clarithromycin, right? Those are good against Bordetella pertussis. And Bactrim is also an alternative if you must. Of course, we want to vaccinate too, right? To prevent these things. All right, asthma. Okay, so asthma. For my family peeps, it's heavy, very, very, very heavy in the asthma. So do not skip learning asthma. You might have 7, 8, 10 asthma questions, okay? You might have 4. And for my family folks, make sure you know each age group as well. You know how it's divided. 0 to 4, 5 to 12, 12 to adult. 5 to adult is pretty almost the same. I don't want to go into this too deep because I have a video, so check it out, that goes in detail of what you need to know. And then I practice some questions with you there too. So if you watch that video and if you memorize that chart I provide you with, you will be able to answer these questions. It's like 20 minutes, that's why I don't want to talk for 20 minutes over this. All right. So this patient, this lady or man, looks like a man here, comes in and everything's out of order. And they're complaining of severe one-sided headache. There's scalp tenderness, there's sharp jaw pain, there's visual impairment, there's sudden loss of vision, right? And then you see and you feel on the physical exam this tender cord-like structure, okay? Their CRP is elevated, the ESR are elevated. What are you thinking? Well, I hope you are thinking giant cell arteritis or temporal arteritis, okay? That's what you are thinking, guys. And this is kind of a big deal. This can lead to blindness. So we want to treat these people right away. We want to give them some high-dose steroids for a very long time, 6 to 2 years. We want to keep them on high-dose steroids, okay? And how do we diagnose this? We diagnose this by temporal artery biopsy, okay? The CRP and the ESR being elevated are supportive, but they're not diagnostic. All right, let's talk about some headaches, because everybody always has a headache question on exam, I promise you. So a middle-aged man comes in and he's white and he's complaining of a headache that's occurring every day at the same time. And there's pain in one eye and it's one-sided, and maybe he has some runny nose and tearing of the eyes that wakes him up. What are you thinking? You are thinking a cluster headache. Cluster headache, and you want to treat them with high-dose oxygen, okay? That's what you are thinking. Now, this patient comes in, and the next patient comes in, and they're complaining of one-sided headache, throbbing and pulsating. It's throbbing and pulsating, and they feel nauseous, and they want to vomit all over you, and they're super sensitive to lights and sound. What type of headache is this? Typical migraine, okay? Typical migraine headache. And tell me an abortive treatment for a migraine, abortive. If you said a triptan, you were correct, right? Triptan. Triptans are always good to give with NSAIDs as well, okay? They work better. Would you give a triptan to someone who has uncontrolled hypertension? No, you would not. You would not. All right. How can we prevent migraine headaches? How can we prevent migraine headaches? You want to avoid triggers, right? You want to avoid triggers. So no chocolate, no alcohol, no artificial sweeteners, no MSG, not too much stress, not too much sleep, not too little sleep. Basically, all of us would be screwed if we had migraine headaches and we couldn't do all these things, right? Let's be real. That's how we deal with this exam, right? Doing all those things. But another option is a beta blocker, such as propranolol, right? That specific one. And there's TCAs and anti-seizure medications, but just think propranolol for preventative. All right. One more person comes in with a headache, and they're telling you that they're having this constant pressure and pain, and it's kind of in a band like, what kind of headache is that? Tension headache, right? Tension headache. I get these all the time. So that's what it is. All right. Now you know the different types, and you can recognize them by these signs and symptoms. All right, let's talk about the heart, cardiac a little bit. Again, I have a YouTube video about murmurs. If you've never heard of Mr. Pass MVP and Miss ARD, get familiar with it. It's super easy to remember how to work out your murmurs. YouTube videos down there. But I'm going to still briefly just ask you some questions on the most common reported things that pop up on the exams. So your patient comes in and you're doing your physical exam. And the patient's elderly, and you hear an S3 sound, okay? What is an S3 sound associated with? Is it associated with heart failure, or is it associated with low blood pressure? Hopefully you said heart failure, right? Especially if they're having other signs and symptoms of heart failure, you want to be thinking that. You know, this could be also found normally in children and healthy young adults, pregnancy, and, you know, under 35, but just remember heart failure, okay? It's basically a marker of poor systolic dysfunction, right, or ventricular overload, so fluid overload. Now you're listening to your next patient, and you hear an S4 sound, okay? And in which condition can you hear an S4 sound? Is it in uncontrolled hypertension or hypotension? Well, I hope you said uncontrolled hypertension, right? Or LDH, recurrent MI, aortic stenosis, something else, or healthy older adults too. But just S4, uncontrolled hypertension. All right. Where is S2 heard best? Where is S2 heard best? Well, and if you look at my little picture right here, you can see S2 is heard in the pulmonic area, right? Or in the second ICS left sternal border, okay? So when people tell you, you have to know your content, you have to know your content, right? If you have no idea where S2 is found, even though it might be a question that's only this long, you're not gonna get it correct. So S2 is found in the pulmonic area, second ICS, left sternal border. Same when we talk about all those typical textbook presentations of the diseases. If you don't know the typical presentations of diseases, you're not going to get the question correct, okay? So anyways, sorry, I got sidetracked there. S2 is the only heart sound that is found in the pulmonic area, right? Everything else, 1, 3, and 4 is at the apex. Let me ask you this. Is S2 split sound normally found on inspiration or expiration? So if somebody has an S2 split sound, is that found on inspiration or expiration? Well, I hope you said inspiration, right? So increases in inspiration and it disappears with expiration. And this is normal. This is fine. This is benign. This is all okay, okay? So the S2 on inspiration is okay. And S2 is found in the pulmonic area, right? Again, in the second ICS, left sternal border. Okay, which murmur radiates to the neck? Which murmur radiates to the neck? Well, I hope you said aortic stenosis, okay? Aortic stenosis, right? So again, you see our little heart here, and where's the neck? That's the one that radiates to the neck. And remember, only systolic radiate to the neck. So whatever questions are given to you, you can, if you remember Mr. Past MVP and you remember that systolic radiate, you can do process of elimination too. Which radiates to the axilla? Well, I hope you said mitral regurg. Mitral regurg. Again, only systolic radiate. This guy goes to the axilla. Which is the only murmur with a click? Okay, so the question is a mile long, and if you just see click in there, you're going to know that it is mitral valve prolapse or mitral valve regurg. It is the same thing. Don't confuse mitral valve regurg with mitral regurg. Okay, I can't talk. Okay, so MVP equals MVR, same thing. The click. Systolic. Okay. What do you find in the fifth ICS mid-clavicle level? Well, I hope you said you find your apex or your PMI there, okay? As you can see. All right, one more. We're going to move on to something else. You hear an S2 fixed split. We talked about just a S2 split. Now this is an S2 fixed split at the pulmonic area, and there's no change with inspiration. What are you thinking? What do you suspect? Well, I hope you are thinking septal defect, okay? You are thinking, that's what you're thinking. You're thinking septal defect, never been fixed, and you're going to refer this patient out if that's beyond your scope. All right, let's move on a little bit to heart failure. So you need to know basics about heart failure for the exam. I just think for real life, you should know more. But this is all about passing the exam. So, left-sided versus right, signs and symptoms. So left-sided, just think of lungs. Because left equals left-sided. Left equals lungs. So L and L. So all the signs and symptoms of the lungs. So crackles, difficulty breathing when you're laying down, dyspnea, cough, lung things, right? Everything else and the left obviously happens first. And then on the right side, it's everything else. It's that JVD. It's the spleen enlarged. It's the peripheral edema. It's the liver. Everything abdominal is kind of enlarged, okay? That's how you're going to recognize the two. So now, true or false? If a patient comes in and they have heart failure, would you want to DC their NSAIDs and their TZDs and their calcium channel blockers? Yes. Yes, that is true. NSAIDs can lead to fluid retention, right? Sodium retention to increase edema. Same with TZDs. TZDs like Actos, right? Because let's assume this patient's diabetic. We do not want our heart failure patients to be on Actos or anything from that TZD class. And same with calcium channel blockers, right? They can lead to edema. When would you want your patient to report back to you if they gained weight? What are those numbers? Yep, so you want to educate your patient to call you if they increase weight by 3 pounds in 24 hours or by 5 pounds in 1 week. They should be calling you, okay? All right, let me ask you this. You prescribe new hypertensive medication to your patient, right? And when should your patient come back to follow up with you? So this is a brand new medication, you give them something. When should they come back? Should they come back in 1 week, 2 weeks, 4 weeks, 6 weeks? You want them to come back in 4 weeks, you guys, okay? I know 2 sounds beautiful because you want to see if they're compliant and everything else. Truly, 4 weeks is when the medication is actually going to start working for them, okay? So choose 4 weeks. What is a first-line hypertensive medication for an African American with hypertension? Calcium channel blocker or thiazides, right? What is the first-line treatment for a patient with diabetes and hypertension? An ACE, and an ARB, right? An ACE, because we want to protect those kidneys. It's kidney protective. Okay, let's say a patient shows up to see you, and they're pre-hypertensive. Okay, so they're borderline. What would you do for that patient? Well, I hope you would provide them with some education, right? You want to educate that patient about lifestyle changes, right? You want to tell them about losing weight. You want to tell them about the DASH diet, sodium restriction, exercising, not drinking, all those fun things, right? Lifestyle modifications. When should a patient avoid beta blockers? In what conditions? COPD, maybe asthma, right? Bradycardia, some heart blocks, 2-3, right? And we want to use it caution with someone who has diabetes, right? All right.